So my name is Rachel Handley. I am just Associate Professor and Consultant Clinical Psychologist working in the UK. My role with the University of Exeter is the Deputy Director of the Doctorate in Clinical Psychology. And I am absolutely delighted to be with you today to talk about PTSD, which is a real passion of mine, and hopefully help you kind of get a sense of how the application of psychology, of cognitive science in particular, to these really distressing and difficult problems that people deal with in their lives can really make a difference, can really transform lives, which has been my experience of applying evidence-based therapies with this issue. So hopefully this morning we're going to cover, or this afternoon I should say, I must get my time zones right. This afternoon we'll cover what is trauma. We'll think a little bit about post-traumatic stress disorder, how it presents clinically. We'll think about how clinical psychology is engaged with PTSD. We'll think about what is trauma-focused cognitive therapy, which is the evidence-based treatment which I apply to that problem. And then hopefully through a few illustrations, case examples, I can give you a real sense of the flavour of what that looks like in real life, in real application, not just the sort of theory. And then, as Alvin says, we'll have some time for questions. So, oh, hang on, here we go. We've skipped forward for some reason. Here we go. What is trauma? So, and that sounds like a very silly question in a way. We talk about trauma a lot in our everyday lives, but actually that in itself can become a bit of a problem clinically, because what we talk about colloquially as trauma it can be a little bit different to what presents clinically. So we often talk about, you know, having traumas with a small t, sort of difficult stressors in our lives, but trauma in terms of a diagnostic description is recognized as something that means exposure to an actual or real threatened death scenario, serious injury or sexual violence. And that can be direct experience, that's something that happens to you directly, it could be witnessing it happening to someone else, it could be learning of trauma happening to someone very close to you, a significant other, or it could be, and this is the case in for example, when people are first responders to incidents, or people who are picking up the phone to emergency telephone calls over and over and over as part of their role, it can be that kind of repeated or extreme exposure to aversive details of traumatic events. That doesn't mean just seeing things on TV or watching any of your favourite hospital emergency programme. That's when actually it's people are in the front line listening to those kind of things happening in real life. So that's what trauma is. You know, it's not just life events or stressors or difficulties that we all might be dealing with every day, but that real sense of real threat to life or the integrity of the self. So clinically then, what's post-traumatic stress disorder? Because all of those things, if any of us experience them, would probably raise our anxiety, mean that we were experiencing some distress and upset in the wake of those kind of problems. But when does it become a disorder? When does it become PTSD to have a reaction to those awful things happening to us? Well, again, diagnostically, the DSM-5 describes PTSD as an inability to recover from psychological trauma. So it's not just being upset by something really upsetting that's happened, but it's actually not being able to recover from that over a long period of time. Depending on the trauma type, the prevalence of PTSD after a trauma really varies. So it can be observed in between 5% to 60% of trauma survivors of different types of traumas. And these tend to differ depending on things like the type of trauma people come into, also the methods that people have used to sample or find out how many people are suffering from PTSD. But generally, PTSD tends to be higher when the trauma was repeated, so not just one event, or man-made rather than something that's a natural disaster. Although you can have PTSD, obviously, to natural disasters, it tends to be when there are incidents which people can really personalise and seem particular to them, that the incidence of trauma, of PTSD is higher. And the main symptoms of PTSD are re-experiencing. So re-experiencing the event as if it's happening again, and we'll talk a little bit more about that because that's very important in PTSD. Avoidance, so wanting to steer clear of anything that reminds you of the trauma, anything that's similar to the trauma, environments, places that are related to the trauma, wanting to avoid talking about the trauma, wanting to avoid thinking about the trauma, etc. Hyperarousal, so that's when people are very, very aware and alert to threat. And people with PTSD, these will be the clients that come and sit in our offices as therapists, and they're jumping out of their seat when a door slams down the corridor and makes a sudden sharp noise. These are the people who will often be sitting at the edge of a room or with their back to a wall, making sure they can scan their environment and see everything that's going on. So that's this kind of hyperarousal symptoms, which also include things like not being able to sleep, not being able to concentrate, but that real sense of jumpiness and being alert. And finally, cognitive and emotional change in PTSD. So these are changes in how people view themselves, how they view the world, often seeing those things as more threatening. And emotional change, so feeling very upset. And commonly with PTSD, we see an emotional change where people are much more anxious, much more on edge, much more fearful. But also there can be emotions of sadness, emotions of anger, emotions of shame or guilt. So lots of changes happen for people who are experiencing PTSD. So thinking about re-experiencing and PTSD in particular, re-experiencing symptoms are really a key feature of PTSD. And this is the re-experiencing that people have of the memory of what happened, but it feels like the trauma is happening again. It's not just a memory from the past. It's not just something that happened to me that I'm describing or recalling and bringing to mind intentionally. It's something that is intrusive, distressing, and feels like it's happening again. And that can include intrusive memories. It can include dreams. It can include flashbacks. We often see that in films now, where PTSD is depicted, and it's very cinematic, lends itself to the cinematic experience, where you see people sort of running through, going straight back to an event, and they can put that up on the screen, so you can have these really clear flashbacks of what happened. Dissociative responses, and those are when people almost, it's like a sense of losing touch with where you are now, so actually being way back in that situation and not really having a foot in the present, not having a sense of connecting with the here and now, but actually being dissociated right back into the past. And people can have physical reactions to reminders as well. So they might not be having an image or a picture of what's happening, but they may be experiencing the emotions and the physiological arousal that came with that event. And again, it feels on some level like the trauma is happening again. These re-experiencing symptoms, as you can probably hear from my description, can be very, very powerful, and they really help diagnose and distinguish PTSD from other disorders, which tend to be treated differently. So people do sometimes have intrusive imagery in other disorders, but actually it's a real kind of core feature of PTSD, which is always there. So it's different, for example, from depression, where people might be bringing things to mind from the past and having sad memories, which they're ruminating on, but again, don't have that same feeling, that same flavor of happening again now. So it's a helpful sign to us as clinicians when we're trying to diagnose and assess PTSD if someone is experiencing something as if it's happening again. But it's important to note that not all trauma leads to PTSD. So you noted there's the statistics I gave, between 5 and 60%, depending on the trauma, depending on the studies that have been done, of people have PTSD after experiencing a trauma, according to that sort of clinical description of trauma. But we know some people don't develop PTSD, and they go on to kind of have a very resilient response to that, and other people do. And understanding why some people do and why some people don't has really helped us understand, and is continuing to help us understand more about the disorder itself and how we treat it. And there are those key clinical questions, therefore, for clinical psychology that really started the ball rolling in terms of developing a good model to treat PTSD. And these questions were, why do some people develop PTSD and why do some not? And also another puzzle around PTSD is why it's often characterized by this sense of fear and anxiety of something happening when actually the trauma is in the past. And fear and anxiety tends to build up in anticipation of something bad happening. Why in PTSD do people have this fear and anxiety about something from the past? And Anke Ehlers and David Clark, who I was very fortunate to work with for a number of years and continue to collaborate with in different ways, really have developed a very elegant model around PTSD based on cognitive science and sound evidence base. And their understanding of why PTSD happens and why it persists is that it's to do with how individuals process the trauma, and when they do so in such a way that leads to this sense of serious current threat. And they go on to explain why this might happen. And there's three key reasons why this kind of you've got this picture of a broken clock here. It's a kind of like there's a sense of time being distorted, this trauma from the past, creating an experience of current threat in the present and a fear for the future. So the reason why people develop PTSD is that when they experience a trauma, they develop PTSD when, first of all, the memory processing, how they make sense of that event and lay it down in their brain, if you like, file it away, is disturbed, so that the memory isn't detailed, it isn't joined up, it isn't time coded in the way that normal memories are, knowing that, for example, this morning for breakfast I had a fruit smoothie, and I know that happened at X amount of time, X time on a Wednesday in February. Actually, these memories are kind of free floating. They're not coded to a particular time and place in the memory. And they are also characterized by poor elaboration. So they're not very clear. They're not contextualized, as we say, joined up, and they're characterized by strong associative memory and perceptual priming, which are psychological processes which basically mean that these memories can be brought to mind very easily by things that closely or nearly resemble them. The second reason why PTSD develops is that the people who have the traumas that develop PTSD tend to think about the trauma and the consequences of the trauma, the symptoms and other things that happen after the trauma, in excessively negative ways. That's not saying that it's wrong to think about a trauma in negative ways. Traumas by definition are negative things that happen to us, and people should think negatively about those, that's normal. But actually, people who develop PTSD tend to develop excessively negative thoughts about what has happened to them. And because of these processes, the trauma is often brought to mind. It feels like it's happening now when it's brought to mind because it's not time coded, and it's experienced as highly threatening because of those excessively negative appraisals. Sorry, my slide stuck. There we go. And finally, the third part of this model is that this problem persists, it keeps going and doesn't resolve because people work really hard to cope with their symptoms, but unfortunately tend to use counterproductive strategies, really logical strategies often, but unfortunately counterproductive, like suppression, trying to push the memory down in a way, avoiding the memory, avoiding all the things associated with memory, and rumination, thinking about it in a ruminative rather than a kind of helpful processing kind of way over and over again. So actually what happens is these negative thoughts about what happened, these excessively negative thoughts, keep going. They don't get to correct those, they don't get to alter those in any way. And the trauma can't get properly processed and put away because people are avoiding thinking about what actually happened. So it's kind of like this picture of the safety lock. I mean, people are working really hard to lock away their memories, to push them down, to avoid thinking about them, really understandably, because it's horrible to think about. And these are the worst things often that have ever happened to them. So it makes perfect sense that they would want to avoid them. But unfortunately, that just doesn't work. What it means is that actually the memory never gets properly processed, sorted through, put away, and actually put in the past. So in response to those, that kind of elegant model around why PTSD develops and persists, Anke Ehlers and David Clark developed this really effective model of trauma-focused cognitive therapy. And that therapy is built on the understanding of how PTSD works, why it starts and why it's maintained. And so therefore it aims to help people with those three key issues around PTSD. It helps them to sort through and elaborate the trauma memory, identifying and discriminating trauma triggers, so understanding what it is that's keeping bringing it back to them, and also kind of putting it away, sorting it through, putting it away in the memory where it belongs. The therapy also helps people identify and modify their excessively negative thoughts, the things that are out of proportion or unhelpful around how they think about the trauma. And finally, it helps them give up those counterproductive strategies, that pushing away of the memory, that suppressing of what's happened, that avoidance of what's happened. To help them, which keeps the problem going, we help them give those up in order to tackle the problem and move them on. So the key treatment elements, the key techniques, and there are many interventions in this therapy, which I won't attempt to explain all of which in this talk today, but I want to explain three key elements that tackle those processes, those cognitive processes. The first is memory processing, or a process we call reliving, which is talking through the memory as if it is happening again. And that helps elaborate and contextualize the memory, and also helps people discover some of the excessively negative appraisals or thoughts they have about the trauma. Second key element is cognitive restructuring. So that's working together, client and therapist, to understand those thoughts, understand why those excessively negative thoughts have emerged, and reappraise what actually happened or what has been happening since the trauma in such a way it helps them resolve those thoughts. And finally, the therapist helps the patient give up avoidance and safety strategies. It helps them stop doing those things which are logical, well-intentioned, make sense, and we all do things to try and avoid things that are upsetting for us, but actually it helps them stop doing that so that actually they can test out how the world really works, what's really going on, what really is threatening and what isn't, so that they can move on with their lives. So I've, to illustrate this, rather than talking technically about theory again, I thought I would just describe a number of cases where this has been applied. These kind of three key elements have been applied. Now these cases are, they're not real names of clients, but they are based on sort of real or composite cases, which I've anonymized. So all of the bits I'm describing are real, all the outcomes I'm describing are real, but they're not real individuals, just for the case of to ensure anonymity, and I'm not breaking anyone's confidentiality here, but hopefully it'll give you more of an interesting flavour of how this works out in practice. So I'm going to introduce you to three individuals. Ashraf, who was in a serious motor vehicle accident when he collided with a drunk driver, so that was his trauma. Sophia was a victim of domestic abuse over a period of 10 years until she finally found the courage and the means to leave her husband. And finally, Farah was caught up in the Asian tsunami in 2004, in which she nearly drowned. So it gives you a sense of the range of experiences that people can come to PTSD treatment with. Each of these individuals, as part of the therapy, early on in therapy, were asked to talk through the memory. Now you can imagine this is the last thing anyone wants to do in therapy. So a lot of what I do when I'm doing PTSD treatment with people is, in fact, any kind of cognitive therapy with people, particularly with around anxiety disorders, is usually asking them to do the very thing they least want to do. So it's confronting the thing they're fearful of and avoiding, because we know that that is the way through to recovery. So each of these individuals were asked to talk through the memory as if it were happening again, running it in front of their mind in the present tense with their eyes closed, and describing, importantly, not only what was happening, but also what they were thinking and feeling emotionally at the time of the trauma, along with sensory information, so what they're experiencing in their bodies. And that's really important, because what people often can describe to you after trauma is what happened, but not that emotional and thought content, which is really important in terms of making the memory coherent and, again, time coded, contextualized and put away. So after reliving for each of these individuals, and it took very different amounts of time for each of them. For Ashraf, for example, it was an individual trauma that happened. For Sophia, we were talking about 10 years of experiences and identifying particular traumas, particular events within that were important targets for reliving. But after each of those episodes of reliving, they all find that actually the reliving brought back more detail of the events, things that have been forgotten or avoided or set aside, that tackling that piece of the memory, in which helps it become more elaborated, more contextualized. All of these clients, along with pretty much every other client I've worked with, find the reliving distressing. And that speaks to the piece I was saying, that in this kind of therapy, we're asking people to do things that they really don't want to do. And that's true of most cognitive therapy, as I say. But actually, what they find, that it wasn't just distressing and that was it, but actually it became less so in places as they returned to the memory. And quite quickly, they started to have relief of some of the flashbacks, some of the re-experiencing symptoms, which started to drop off as they engaged in this process. And importantly, through the reliving, it wasn't just about emotionally processing or putting together the pieces of what happened, but it was also about identifying the worst moments, the hot spots in the memory, the thoughts that connected to those. So these kind of moments that we then knew we needed to target in the rest of the therapy. So when we've done a reliving with our clients, and as I say, that may be through one key trauma that's happened to them, or it may be through a number of traumas that have happened to them over a period of time. What we do is we identify these hotspots, these key moments that were worst moments for the clients. And for each of these clients, just to give you again a flavour of the kind of things that people think, they had different moments, and to select three, for Ashraf, the worst moment, or one of the worst moments for him, was sitting pinned down in his car after the collision. And his thoughts were, my legs are crushed, I'll never walk again, I'll never be a good father to my boys again. And his concern was about the fact that he wouldn't be mobile, he wouldn't be able to use his legs. Sophia, describing one hotspot in her long chain of events in her domestic violence situation, described one hotspot as being violently assaulted by her abusive partner. And I won't go into details here, obviously, but her thoughts were, I'm worthless, this is my fault. For Farah, in her experience of the tsunami, one of the hotspots was a moment where she was actually swept under by the water, swept away from the tree that she was able to hold on to. And her thought was, I'm going to die here. I'll never see my family again. So these give you a flavour of the kind of thoughts people have in some of their worst moments, and very different for each different client. So in each of these cases, the next step we move towards, having done the reliving, having identified these key thoughts and key hotspots that people have, is the therapist and the patient work together to identify the worst thoughts. So really drilling down to, what was the worst thing about that moment? What was the worst thing about that thought? You were going to die. And that sounds like a funny question to ask, because people often think, what's worse than thinking I'm going to die? Well, as we've seen in one of the cases, actually, for Farah, the thought was not just that I'm going to die, but I'll never see my family again. And often that's what people describe, that it's not just the idea of death or serious injury that worries them, there's some other consequence of that that's even worse for them, that's individual to their own experience. So we identify the worst thoughts. We consider the veracity, how accurate, how helpful those thoughts are. And by this stage in therapy, you've got lots of evidence to draw on, because often from the reliving itself, we've got evidence that contradicts the worst thoughts that people had at the time of the trauma, because they didn't know any better at that time. We also find evidence from other sources, from surveys, from speaking to other people about what's the worst things that can happen in these situations, how the world really works, that help contradict or balance out those really excessively negative thoughts that people have. The patient and therapist work together to build more accurate and helpful cognitions. And once they've done that and rated the patient's belief in it really importantly, because if the new thought isn't believed, then it's not going to be very helpful. But if it's believed, if it really makes sense, then the hotspots, the worst parts, are revisited again in the reliving, going back to those worst moments. And those new cognitions, those more helpful, accurate appraisals, are inserted back into the memory simply by the client saying, and what I know now is that, and we'll come on to how that works with each of the individuals we talked about. So for Ashraf, for example, his thoughts that his legs were crushed, he'd never be able to walk again, never be able to be a good father to his boys, were able to be contradicted by lots of information he has had since that time. So he knew that, for example, although his legs were injured in the accident, he was able to learn to walk with rehabilitation and physiotherapy. He was able to walk again. Although he was not back to his former function, and he was never able to play football again. And this is a key thing for him, the idea that what meant to be a good father was that someone who was going to be physically active with their children. And in particular for him, with his children, it was the way they bonded over playing football together. But he was able to kind of realise that although he might never play football again with his boys in the way he did before the accident, there were so many other ways in which he was a good father, and so many other aspects to being a good father, and that meant a huge amount to his children and connected them in ways that he at one point was thinking that their connection was really only over this one sort of physical interaction that they had. So he was able to say that in many other ways I show I'm a good father to them, including reading to them, talking to them, swimming with them, caring for their basic needs, comforting them when they're upset, and on, lots and lots of information and evidence that he was actually an engaged and caring father. And that they tell me that they love me, and my wife tells me every day that I'm a good father. So he had lots of evidence against that. So with Ashraf, we were able to go back to this point in the trauma where he's sitting in the car, thinking I'm pinned down, my legs are crushed, I'm never going to walk again, I'll never be a good father again to my boys. And actually then say, and what do you know now? And Ashraf was able to update that with, and I know now, again, all these things that we've noted under this alternative appraisal. And to really change the meaning of that moment for him and depower that excessively negative appraisal. For Sophia, she had the thoughts which are very common with people who have domestic violence or sexual assault or childhood abuse. These thoughts of being worthless and thinking that actually the assault was her fault, which again is often something that the perpetrators of these assaults, really play on with their victims. And these kind of thoughts tend to take quite a lot longer to work through in therapy because you have to draw on lots of other information. You're working against often years of evidence that people have been building up internally that they're worthless or something is their fault, or that they're not worth being treated in a different way. But with the help of the therapist, Sophia was able to work through, their appraisals and realise that actually, although her husband treated her as if she was worthless and told her that the abuse was her fault, she was not worthless, and that was actually another way of controlling and abusing her. She was able to realise that no one deserves to be beaten and abused, no matter what they do, so the fault always lies with the abuser. She was able to understand that she did have worth and build up a portfolio of evidence around that from different interactions with other people, including how she's loved by her family and friends, and to note lots of different characteristics, including the fact that she's intelligent and kind, and that she was brave, that she managed to survive the abuse and make a new life for herself away from her ex-husband. And again, this information would be inserted back into the worst moment of the trauma, reliving it and pausing and saying, and what do you know now? And Sophia was able to account the new appraisals and more helpful appraisals, which depowered the old excessively negative appraisal. Finally, Farah, her thoughts were she was going to die here. You remember, under the wave and tsunami, I'll never see my family again. There was some very obvious information we could insert back into that trauma, and that this is commonly the case when there are traumas involving sort of near death or threatened death experiences, simply that she did not die, that she is here. And of course, a client intellectually knows that, and when they're sitting in the room with you, but when they're flooded by the re-experiencing of the emotion of the memory, they're not connecting with that fact that they didn't die. They're connecting with the fear that they're about to die. So actually bringing this information back into the memory depowers that, helps the memory be processed, helps correct those negative appraisals. And not only that, but she was able to kind of think about all the times she'd seen her family since that, and bring evidence into the memory as well, a picture of a recent event, the celebration with the family that she was able to hold up and consider when she was in that point in the memory, thinking, I'll never see my family again. Really concrete evidence that, hang on, there we are, only a couple of months ago, celebrating my dad's 60th birthday. So time has moved on. Again, contextualizing, joining up and putting the memory in the place where it belongs, in the past, and correcting those negative appraisals. The final step that I'm going to describe, I'm just keeping a little eye on time, is giving up avoidance. So you remember we talked about the last thing that keeps PTSD going is the fact that people will avoid approaching both the memory itself, which we will have done through the reliving, but also other activities that remind them of the memory or that they're fearful of since the memory happening. So Ashraf, you'll remember, had a motor vehicle accident, road traffic accident. And as is common with lots of people in that situation, he'd avoided driving ever since the accident. Not only that, if he was in the car, he's the passenger you wouldn't want in your car, the one who's telling you, backseat driving the whole time, telling you what to do and what not to do, telling you to slow down if he thinks you're going fast, even if you're under the seat, speed limit, looking around the whole time, scanning what's going on around. So Ashraf was very hypervigilant and displaying all the symptoms of hyperarousal whilst he was in a car. And car journeys had to be in complete silence, no radios on, no talking, just everyone focusing on the road. Really understandably, having had such an awful accident himself, trying to desperately make sure that that environment was as safe as it could be when he was in a car again. However, working with the therapist, Ashraf reappraised this situation and his fear, his absolute certainty, almost certainty that when he got into a car again, and particularly if he was driving, he was going to have an accident again, despite all the probabilities that suggest otherwise. That was his emotional belief. So the therapist and Ashraf worked together to reappraise that likelihood, to think about, well, how often do accidents happen? How often in particular have they happened to you? And this is the only accident he had been in, despite a sort of 20-year history of driving. So although accidents do happen on the road, he was able to realise that his estimation of a 90% probability that he would have an accident when he got into a car was way out of proportion and exaggerated from the actual experience that he'd had over the years of driving, where he'd had no accidents up until this point. So that helped a bit, but then the really important thing to do with avoidance is to reverse it and to give up, as we said, those counterproductive strategies. So Ashraf had to start to get back into a car. And when he did, first as a passenger and then eventually driving himself, he was able to discover that the things he was doing to keep himself safe, his hypervigilance, his looking around the road constantly, looking behind him, looking in front of him, almost on a kind of constant basis, and checking his speed limit, looking down at the dashboard to check his speed limit, was actually distracting him much more from the business of driving than if he had just been driving as he did before, focusing on the road in front in a more relaxed way. And actually it was also making him much more anxious, because the more we're scanning for danger, the more we're raising our anxiety, because it's like telling ourselves this is going to happen. I must be vigilant and aware of it at all times, and of course that's going to keep us on edge. So it was reinforcing his belief that the accident would happen and actually decreasing his safety on the road, because he was scattered and not concentrating fully, in the sense that in a relaxed and normal manner on the road in front of him. So over time, he was able to start to drive again, first with his therapist in the car. We end up doing lots of funny things in PTSD therapy and going interesting places with people, including back to the sites of traumas very often. But first with his therapist in the car, and then finally alone and giving up those unhelpful strategies, and becoming much, much less anxious in his car until he was able to do that without thinking about it in the way he did since the trauma. Sophia, understandably, had a huge avoidance of situations that reminded her of her abusive husband, and in particular, any man who would remind her physically of her husband, in his stature, in his voice, in his facial expressions, etc. She would avoid anyone like that. And where possible, in fact, she would avoid all interactions with men outside of her immediate family or people she knew very well, and was particularly terrified of any relationships because she felt that she were in a relationship, she would be vulnerable, and that given her belief was that all men were dangerous and would abuse her if trusted, she did not want to get into that situation. So working together with her therapist, Sophia was able to reappraise her excessively negative beliefs about men in general, which were based on this particular experience of one man who's abusive. She was able to understand that her attention was drawn, if she was reading the papers or watching the news or engaging in social media, that her attention was naturally going to be drawn to reports of violent behaviour rather than to those examples of men behaving in kind and gentle ways, or being good citizens, or being loving husbands or fathers or boyfriends. So Sophia learned to kind of try and readdress that balance in her attention and take note of that other information when she saw men around her behaving in kind and gentle ways. She experimented with talking to men and over time developing friendships in her work and social circles, and always noticing the difference, discriminating the difference between what happened during the trauma, the man who abused her, and actually these other men who weren't that abusive man and actually were safe, kind, thoughtful, and restrained. And at the same time, she was working on developing her sense of self-worth, her assertiveness, an understanding of acceptable behaviours in relationships, because as you can imagine, abusive relationships leave people vulnerable to believing that certain things are normal in relationships, which really aren't or shouldn't be, so that she could choose over time to spend time with men who were respectful for her and lay the basis, the foundations for the potential for a future relationship, should that be what she wanted to do. Farah, the lady who was involved in the tsunami, had been a keen swimmer and lover of the seaside. That's why she was there in the first place prior to the trauma, and had completely avoided both swimming and the seaside since the trauma. She was terrified of being reminded of it. That's one reason why she was avoiding it. Also thought very likely that another tsunami would happen again if she went to the seaside. And again, we worked on those probabilities and the fact that this is the only time she'd ever experienced this in the whole of her life and experience, and how likely these things were to happen to her again. And working together, the therapist and Farah developed approached pictures of bodies of water. So rather than just going straight to the seaside, it was kind of graded approach to noticing the difference between these pictures of water and what happened during her trauma. And then gradually approaching various settings in real life, so swimming pools, rivers, lakes, and eventually going to the seaside, until none of these any longer triggered unwanted memories of what had happened to her. Over time, she experimented with paddling, sort of getting into the water in different modes, and then swimming, and then first inside her depth, being able to stand, and then being able to go out of her depth again. And she achieved her goal of swimming regularly again. And a really important aspect, as you will probably know about CBT, is that we're not just tackling technically the problem that people have, but what we're always doing from the first moment in therapy is working towards the individual's own goals for their recovery. So it was really important to this lady that she was able to swim again. And that was therefore something that was very motivating and important to her. So after this therapy, and these are three of the sort of key interventions, but not the whole of the therapy, but after the application of trauma-focused cognitive therapy, Ashraf, Sophia and Farah are able to continue with their lives without distressing re-experiencing of their trauma. This does not mean, of course, that the trauma has been wiped away, that it never happened, that it's, you know, somehow magically erased from their lives. The things that happen to us are always part of the fabric of our lives and who we are, but really importantly, no longer define the person or their daily experience. They're no longer haunted by these awful, upsetting, re-experiencing symptoms day in, day out. The memories are still not pleasant things to think about. They're still not things that they look back on, smile on, and they never will be, but they are not aspects of their life that control them and, as I say, define them anymore. So they were able to re-engage in their previously valued activities and goals, the things that they really wanted to do. And their trauma and losses, as I say, are still part of the fabric of their lives, but don't define or control their current choices or future hopes. So hopefully that's given you a sense of how psychology has engaged with this knotty problem of PTSD, why it happens, why it persists, most importantly, because, as I say, any of us can have really negative reactions to bad things happening to us. I'm sure all of us on this call have had things happen to us that we've thought about again and felt anxious about. But this knotty problem with PTSD of why it persists, why it takes over, takes hold, takes control of people's lives. Hopefully it's illustrated the key processes that are happening there psychologically, and how this evidence-based treatment based on the cognitive processes we know are happening for individuals engages with that and helps them move on towards their goals, towards freer, happier and more fulfilled lives that aren't defined by the trauma. So I would be really pleased to take any questions that anyone has in the remaining time.
Yes, Rachel, there are quite a few questions coming in already. I'll read them out for you. Okay. Hang on. Okay, first one. Hi, Dr. Rachel. I noticed the key treatment elements were presented in order. So that's 1, memory processing, 2, cognitive restructuring, 3, giving up avoidance. Would you recommend the treatment plan to follow this structure, or is it possible to start with replacing maladaptive coping behaviors, for instance?
That's a really question. Is that Emmeline?
Yes, that's right. Yeah.
Thank you for that question, Emmeline. That's a great question. And I think the trauma-focused PTSD model tends to follow that sequence, but not always completely linearly, and it's not the case that you finish one piece of the work and go on to the other. Often they're intertwined and interwoven throughout therapy. The reason it usually sort of works in that order is that in order for people to engage with the things that they've been avoiding, they actually need to understand why it is they've been avoiding it. They need to approach the memory and think about what it is that's been excessively negative about that, in order to give them a platform for understanding why it is they're avoiding something else, and a reason and a hope and a sense that they can manage to engage with those things. So it is helpful for it to be in that order. However, with cognitive therapy, we're always working not just to a kind of strict protocol where you do step A, step B, step C. We're thinking about a formulation, a whole formulation of the individual and how the problem is working for them. So it may be, for example, that someone has such a patchy memory of what happened to them for various reasons around the trauma, that one of the things they need to do in order to process the memory and work through what happened is to go back to the site of where the trauma happened, to help fill in some of the gaps, which also helps reverse some of their avoidance and helps them deal with some of the things that they have been suppressing, not engaging with, pushing away. So the model is flexible. It usually works in terms of getting more information about the memory first, which helps you understand the appraisals, which helps you deal with those, which helps you then think about what's getting in the way of engaging with life. But it is flexible because actually it needs to be to help you apply that to an individual, if that makes sense.
Right. Great. The second question here is, what's the time span of therapy in each of the 3 cases that you mentioned earlier to teach their goals? And would you say hypnosis is or is not quicker therapy over CBT, and what are the risks?
Okay.
That's a typical question that we tend to get almost every time. So then,
That's
hypnosis.
really interesting, and thank you for that question. So to take the first part of that first, in each of these 3 cases, I can't remember the exact length of therapy for these individuals, and as I mentioned earlier, kind of composite cases, but what I can tell you, what's typical in terms of the evidence base is that for sort of individual single event traumas, or up to three events which people have intrusive memories to, you might expect to see a course of therapy which is 8 to 12 weeks for that, and sometimes with follow-ups on a monthly basis for a few months, just to kind of think about any residual symptoms. So that can be, as quick as done in 3 months of weekly treatment, and there's no reason why it has to be weekly. There's really good evidence now around applying this treatment intensively over a period of a week. So there's no magic around having weekly therapy. So with kind of events like a motor vehicle accident, I might expect that someone might do really well in 8 to 12 sessions of trauma-focused CBT. When we're thinking about someone like Sophia, who had 10 years of domestic violence, that's you can, as you would expect, there are many more incidents that had happened than one in her scenario. And with that kind of complex presentation, I might still expect that I could make a lot of headway in 12 sessions, actually, and often where the events are very linked, and the same sort of thoughts coming up, the same scenarios replaying. Through working with 1 or 2 memories, you actually get a sort of domino effect where their thoughts and appraisals and fears actually dissipate to the other memories, because actually you've dealt with the key meaning of the events for them. So it can seem really overwhelming when you're sitting with someone in a therapy room with lots and lots of traumatic events, but actually when you boil it down and you look at some of the worst moments for them and those things that are common to those memories, actually you can get very good traction. But the evidence base would suggest that people who have complex traumas, and many symptoms to their PTSD, and maybe many events, you might be expecting to have at least 20 sessions with someone like that, and often people can have 30 or more sessions around that with complex trauma. But it isn't the case that just because someone has multiple traumas that it can't be dealt with quite quickly, because that can happen too. And if they have childhood trauma as well, that can often add a sort of layer of complexity to what you're dealing with. But again, can be surprisingly simple when we come back down to that key question of what does the trauma mean to them, and what is it therefore they're carrying through to everyday life, and the responses to the memories around that. In terms of hypnosis, I'm absolutely not an expert in hypnosis. I've never used it, and so I'm not really well equipped to say whether that's a quicker therapy over CBT. What I would say is that the evidence base wouldn't suggest that hypnosis is a first-line treatment for PTSD. It doesn't really feature, certainly in the NICE guidance, which we refer to in the UK, around engaging with PTSD. There are a number of very effective treatments for PTSD with a good evidence base, including things you may have heard of like EMDR, cognitive processing therapy, prolonged exposure. And what is common to those treatments that tend to be very effective for PTSD is they all involve some exposure to the memory and some processing, as I talked about earlier, of those events. So rather than avoiding talking about those events, actually thinking about them explicitly and making sense of them. So that's a very partial answer to your question. I do not think that hypnosis is kind of as a first line recommended treatment for most of the problems which CBT would be a first line treatment for. But I not being an expert, I would not be my place to comment more on the treatment length for hypnosis.
Okay, we've got wow, 4 more questions. I think we'll just keep to these 4. Yeah, it's coming to the end of the hour. All right, from Brian Lim, for Ashraf and Farah, there's that traumatic events are specific versus Sophia's one. Is there a difference in treatment techniques since the traumatic materials can be so different?
Thank you for that, Brian. I think I probably touched on that a little bit when we were talking about treatment length. So the techniques are the same. The approach is the same, and they're the same because the underpinning mechanisms for how the problem is working are the same. The difference is that, as you say, you're dealing with a vast amount of traumatic material. So there could be hundreds of events that you're dealing with in terms of someone who's had domestic abuse or indeed childhood sexual or physical abuse in the home. So the real art comes in, the art of the science really comes in helping the client identify what were the worst traumas, thinking about, as I said earlier, thinking about what might be a typical trauma, where you might get a lot of traction working with the thoughts and appraisals and fears that occurred during that trauma. Or it might be the worst traumas, or it might be starting with them working with some of the most recent, or even indeed working with a memory to start off with that isn't one of the worst, but actually you can get a lot of traction, of a lot of movement with, so that actually the person can then trust in the process and approach some of the worst memories after getting a little bit of hope from, well, I can deal with that particular memory where perhaps maybe I thought the worst thing that was going to happen to me was that I was going to be badly injured, and then I can go back to this other memory where actually I thought I was going to die, and I had some of the worst thoughts about myself or the perpetrator, or I had some of the more shameful or memories or guilt-laden memories that I haven't yet been able to approach. So the technique is the same. The art comes in helping identify people and narrowing down to the particular memories you're going to start with. Often we'll start with sort of timeline and identifying, again, sort of pinpointing moments in the history that are really significant and pinpointing memories that you can work with in this way. But as I say, it can feel overwhelming, it can feel vast and difficult, as you say in your question. But actually, bearing in mind the model and the process of what's going on, you can actually see huge change quite quickly and real benefit to the individuals. I think often what happens in trauma therapy is people think, it's really complex, it's really big, it's really difficult. I need to do something really complex, big and difficult to approach it, but rather than it coming back to the theory again and the science behind it, which says that this is how the problem is working. Here's what we need to do to help it, and helping the client narrow it down and make progress with what they can.
All right, the last 3 questions, I think they're quite related. One is about re-traumatizing the client, as part of reliving, and how do you manage clients who are strongly opposed to the reliving process, and do any one of them actually respond in an aggressive way, hysteria, violence? Yeah.
Really great questions, and really reflect often some of the anxieties people have about engaging with this work when they're doing PTSD work for the first time. And often therapists who are very experienced working with other problems really worry about PTSD because they think it's something magical and mysterious and different that you have to do. And really that worry about re-traumatizing people is a question that comes up almost every time I speak about PTSD. And I guess not to oversimplify it, but simply to say that the clients that we see with PTSD are re-experiencing their trauma day in, day out, often hundreds of times a day. Their brain is throwing this at them constantly in a way that feels like it's happening again. And they are hugely distressed and upset by that. When we do reliving in therapy, what we're doing is we're taking them through the memory, taking the worst places they want to go, but we're doing it in a controlled way, which is going to help them process, put away, and recover from the trauma memories. So actually in therapy, you are not doing anything worse than that person's brain is doing to them every day. In fact, what you're doing is giving them a sense of control and giving them actual control over what's happening to them. So yes, it's upsetting. Yes, it's, you know, it's hard, particularly in the early stages of working with PTSD. When you first do reliving with someone, you just you know, because you haven't seen them get better yet, you think, oh, I'm doing something really terrible to them. Actually, when you see people go through it, and you see how empowered they are, even by the sort of early relivings when they're going through awful stuff and they're crying and they're distressed, but actually they're saying, you know what, actually this is helping me understand, this is helping me move on, and quite quickly often helping those re-experiencing symptoms. The key thing I always keep in mind is I'm not re-traumatizing them. Actually what I'm doing is helping them get better, and what we're doing in therapy is, you know, no worse than what their brain is doing to them every day. In fact, it's part of the healing process. When we do it with a client, it's, you know, as I said, it's the last thing they want to do. The whole reason they're in therapy is because they've been avoiding thinking about it. And then one of the first things you say is, what we're going to do is think about this in detail. So, you know, talking about people who are strongly opposing it, you know, one of the points, because I focused on the three key interventions in the treatment, but a huge part of the first session or two is engaging someone in the rationale for doing that. We never do anything in CBT without the client understanding why they're doing it. So, you know, that's a key part of the therapy, is bringing someone alongside with you. I don't expect my clients to come in and say, what I really want to do with you today, Dr. Handley, is I really want to talk in detail about the memory. But if anyone ever did that, they probably shouldn't be in the therapy room, because actually they're okay. But it's my job to help them understand that, a bit like, and we use a lot of metaphors talking with our clients, it's a bit like cleaning a wound. So when you do it with antiseptic, or, you know, it really stings, it really hurts, it's last, you want to cover it up and just push it away and not look at it. But actually that wound's going to go septic, you know, and before long it's going to, you know, creep and get worse. And actually this is why we're doing what we're doing with the memory, or talking to them about you know, really helping them understand the effects of suppression and avoidance. So we do little experiments around, for example, if I said to you all now, you know, you can imagine anything, if you closed your eyes for the next 30 seconds and imagine anything except a pink rabbit sitting on my head. And we don't have time to do that right now, but if I did, I can guarantee that the majority would probably be able to think about nothing else other than a pink rabbit sitting on my head. So, you know, we have these tricks and these tools, but all illustrating those really concrete cognitive processes that we know that happen as soon as we try to avoid thinking about something. Of course, what we're making our mind do is filter that, and therefore it's looking out for those things happening. So actually our huge part of our therapy in the early stages is engaging someone in the idea that this is not what you want to do, but this is what's going to be helpful, and here's what your mind is doing to you, and here's how we're reversing that, and giving them hope and engaging them collaboratively in that process. In terms of strong reactions, there are always strong reactions. There are always emotion, distress, and difficulty. I've never experienced violent behaviour from anyone. Hysteria, I guess it depends how you define that. For people very, very emotional, usually people's fears of how they're going to respond to the traumatic material are much worse than the actual reality of what they experience when they go through the reliving. And they're very relieved by that. It's part of their giving up their avoidance, actually, is going through it. Of course, with all clients that you work with, I'd encourage you to do a risk assessment if you think that there's been any prior violent behaviour or dissociation associated with that for a trauma, and you would always do that before embarking on this therapy. But you know, what I would say is that most generally, what you're actually helping the client is realize their fears, that if I start thinking about and talking about the trauma, I'll never stop crying again, or I'll go mad or crazy. Actually, what we're helping them is engage with that and find out that, do you know what, I can approach this thing, and in doing so, I'm depowering it, and it's transforming my life.